Hello everyone, this is Roxon Liu from Oakland, California with a robotic tap right angle hernia repair. I chose this video because this patient had quite a bit of fat in the preperitoneal space, and then there was also a large cord lipoma that contained a significant amount of lymphatics, which I have not encountered in the past, and just wanted to show you how I dealt with it. The video starts with the peritoneal flap already started. I'm continuing the peritoneal flap across towards the medial umbilical ligament, and just wanted to show how I picked the planes. So here you can see I've exposed the retrorectus plane. There's the intermediate fascia or attenuated posterior rectus sheet that I just divided to connect the retrorectus space with the bowel space. Now, normally I stay in the visceral space between the attenuated posterior rectus sheath and the peritoneum, but I immediately noticed how fatty the preperitoneal space was in this patient. So I decided to just jump into the retrorectus space and try to keep some of the fat on the peritoneal side so that the direct space would be easier to expose and also Cooper's ligament would be easier to expose. As usual, laterally, I try to stay against the peritoneum, and here, my eyes just is kind of trained on all this fat and saying that it really needs to stay up against the abdominal wall, which is why I cut through it in a kind of a longitudinal fashion and then sweep it against the wall. Here I'm getting towards the transversalis sling. This is, sorry, the radius space, but you can see the transversalis sling laterally starting to show up. Here, sometimes I'll jump anterior to the retrorectus fat, but in this case, I'm following the plane between the retrorectus fat and the bladder just to see where it takes me. Sometimes it really exposes Cooper's ligament. Um, but you have to be careful about leaving the retrorectus fat on the ceiling against the rectus muscle because sometimes it can hide a direct inguinal hernia. Um, Later, I'll talk about how I manage that situation. So here is reduction of the sac. Medial to the indirect sac is usually the transversalis sling. When the defect, when the sac is a little larger, the sling is usually more prominent. So the left hand retraction again is really important. You can see with good retraction, cotton candy shows up, and that's easy to follow. Good plane when cotton candy is present. So fat, of course, comes off the sac. So I'm right now trying to just divide the fat and get right onto the peritoneum uh, surface of the sac. There's some of the transversalis sling that I'm starting to divide in order to free up the sac to reduce. The sac should not have any vessels or fat, so I'm just going circumferentially around it. So laterally here you can see some fat, so I'm going to cauterize it to get right onto the sac. There's some of the transversalis sling, lots of fat, so I'm going to cauterize right through it. I don't see any testicular vessels, so I know it's safe to cauterize. I'm doing it very carefully. Take more of the transversalis sling, go all the way around it. Now the cautery around the sac from between kind of the 9 o'clock position and the 4 o'clock position is pretty safe. And this requires good tension with the left hand. And as I'm doing this, I can see near the internal ring that there's a big piece of fat. So I'm keeping that in mind, and I'm going to come back to it to try to reduce that large cord lipoma. But my goal right now is just to finish separating the sac from the testicular vessels in the vas deferens. And I like to pull towards about 7 o'clock and use my scissor to sweep the tissue down to really expose the layers of the tissue right there. See, I'm pushing down with a scissor. I just want to see that junction between the vas deferens and the sac, create tension so that it's easy for me to divide it with the side of the scissor and a little bit of cautery. And once I get that groove going, I can follow it down into the pelvis. But right now I chose to deal with this cord lipoma. So this it was very easy to reduce. And normally I can free it up from the retroperitoneum and not injure the endo-abdominal pelvic fascia. But in this case, it looked like it was emanating from deep to the iliopubic tract from some of the femoral tissue. So right now, just one, creating space for the mesh, and two, figuring out what to do with this big lipoma. If I left the lipoma as is right now, of course, the mesh would be sitting on it, and that could be a lead point for herniation of the fat back into the inguinal canal. So here, I don't like how much fat is on the ceiling against the rectus muscle, so I'm going to cut through it at a reasonable place. Usually I'm thinking, okay, I'm starting at the top of where direct space would be, and I'm going to bring down all this fat just to make sure I'm not missing a direct inguinal hernia, but also to come down onto Cooper's ligament so I have a better idea as to where to sew my mesh. And this also helped me dissect down that groove so I can get down to the obturator space and peel the bladder and the fat away from the external iliac uh, vein. Getting 2 centimeters deep into the retropubic space and making sure I'm dissected 2 centimeters across the midline for good mesh overlap around the direct space. Continuing to prioritize the cord structures to make sure I have a good posterior landing zone for the mesh, and then dissecting down that groove between the bladder and the external iliac vein. You'll notice that I'm leaving some fat on the external iliac vein, and I try to do that when possible just to prevent mesh from sitting right on the vein. So now I got to figure out how to manage this cord lipoma. So I'm looking to see if there's a natural uh, plane I can use to separate the cord lipoma or divide the cord lipoma. In this case, it doesn't seem like there's any natural plane for me to lift it off of the retroperitoneum. And as I'm dividing here, I'm starting to see some clear liquid leak, and realize that there's lymphatics in this lipoma. And never had a lymphocele, but these are the situations where I'm worried that a lymphocele could develop. So I'm still trying to find a good plane to divide the lipoma, because I just don't want to divide the lymphatics. And here I have everything stretched out, and you can really see the multiple lymphatic channels traveling through this part of the lipoma. So I've decided to clip these lymphatics, which is why I'm creating these little windows so I can get my clips around these bundles of lymphatics. You see, it's just a very broad base for this lipoma. You can see the femoral branch of the genitofemoral nerve there, protected by a microfascial layer so that the mesh does not sit directly on the nerve. And when there is a lot of fat in the extraperitoneal space, hemostasis is absolutely necessary. Otherwise, it's really hard to tell one structure from another. It's hard to tell what's peritoneum, what's testicular vessels, what's fat, what's lipoma fat, what's normal fat. You can see with good hemostasis, I can really see the plane that I need to develop the right size pocket for a good mesh placement. So here you can see the entire base of the lipoma and what I'm going to need to divide. Just cleaning, isolating, getting ready to place my clips. all the lymphatics. See, they're somewhat engorged. There's one that I've divided, so I'm making sure that I go back and clip that divided lymphatics. These are medium large wet clips. That's the one that I've already divided. So this patient did very well. There was no lymphatic leak. I was also worried about creating or causing chronic pain by having clips so close to the genital branch. Um, but there was no issues with chronic pain. I purposely clipped a little away from the retroperitoneal tissue so that the clips wouldn't sit right on the genital branch. There's a last clip. So this lipoma gets completely divided. I almost never remove these lipomas. Um, Most of the time, I just leave it in the pocket, have it sit on the mesh. There you can see the actual the white genital branch is right back there. So the rest of the operation was pretty standard. Put in the extra large 3D Max Mid here. Making sure it's tucked vertically into the retropubic space. The T intersection sits right where the vas deferens comes out of the internal ring and goes around the inferior epigastrix. And I place a single suture onto Cooper's ligament. Um, Normally I clear out Cooper's ligament pretty well, but I think I had seen that little window um, where the fat was a little thinner, so I didn't feel I needed to clean out the rest of Cooper's ligament. Normally I do use a purple stitch. This is a different hospital than where I normally operate at, and they did not have any purple vicryls. And there's that large cord lipoma. I just leave it on the mesh and close a flap over it. I've never had any problems with the lipoma causing any issues, seromas, pain, um, prolonged inflammation, etc. So I've left some pretty large cord lipomas in there. This is I believe a 90-day VLOC. Normally I use a 180 day, but again, this hospital didn't have this, the typical sutures I use. And so this is closure of the peritoneal flap, pretty routine closure. And of course, at the end, I like to evacuate the CO2 from the pocket to make sure my mesh is sitting well. So the last few throws of the suture are going to be left loose. I stick my left hand in the fenestrated end to stent open the peritoneal flap opening, and then point the needle driver into the hole and have my bedside assistant then insert a suction cannula without the suction irrigator to just evacuate the CO2. The intra-abdominal pressure uh, will push the CO2 um, out of the pocket. Well, thank you for watching.